Assalamu alaikum wa rahmatullahi wa barakatuhu. Hi guys, and welcome back to the channel. If you're new to the channel, karibu sana. My name is Sheba, and in today's video we're going to be talking about the differences between BSc and Diploma Clinical Medicine from an internship standpoint. While going through internship, one of the things that our supervisors made very clear at the very beginning was how different our schedules were going to be. Different in the sense of like what a diploma clinical officer intern schedule was going to look like and what a BSc clinical officer intern schedule was going to look like. While a lot of the things that we did were somewhat overlapping and like were similar, and this cuts across all interns, there were a few things that were noticeably different, and that is what I want to talk about in this video. These things could actually be different. You could go to an institution where all interns are treated the same. I don't know of such institutions, but I know of certain situations where that would be applicable, and this is primarily when there is a lot of shortages, where like the interns are like very few compared to the number of patients and compared to the number of maybe registered MORs and registered COs who are working in the facility. So the interns have to pretty much do a lot of the work, which is what interns do, but then do a lot more of the more work that they do. Then the other disclaimer is that I say that this is going to vary from institution to institution, and that you're going to maybe go to an institution, or like maybe you went to an institution where, by institution I mean hospital, where BSc clinical officer interns and diploma clinical officer interns were pretty much treated the same way, and you can go to other institutions where this difference is pretty much amplified and it's pretty much like put out in the public. One, let's address the elephant in the room, the working hours. For us BSc clinical officer interns, depending on the institution that you go to, again, we are expected to do what we call calls, and the diploma interns are not expected to do calls, or like it's not part of their requirements to do these calls. What is a call? A call is pretty much the night duty, and it says that it's called a call because you are on call, like you literally are on call. You could be called in anytime. But how public hospitals are is that, one, as we all know, hospitals run, at least the majority of them, and all public hospitals run on a 24/7 kind of service, and like they're open every single time of the day. Like that's why we have like circulating shifts, and we have people covering the units, different units and departments in the hospitals at every single time. That's why we have a thing called on call. Now, being on call means that you are, for example, if you're rotating in obs and gynae, you are on call for any obstetric case, any gynecology case that comes into the hospital during the night hours. While ideally you are supposed to be somewhere maybe at home, you're supposed to be somewhere maybe rested, and then when a patient comes in you get called, but then the reality of the matter is that the work kind of still continues, and you just find yourself being there in the hospital throughout. You as an intern, you are the person who is first on call. So there is first on call, second on call, and then third on call. And first on call is you, the intern, and if an intern is absent, then the MO or the CEO, the medical officer or the clinical officer is the first on call. And then we have the second on call. Again, in the case where the intern is available, you have the first on call as the intern, and then this most immediate supervisor of the intern is who is the second on call, and then the consultant at this point is the one who is coming in as the third on call. Now, as the intern, again, you are the person who is on the ground, and you are the person who is on call. Well, this was a pretty much interesting thing, because going through medical school, I don't remember going through nights during my training. I did go to do nights in the hospital. I didn't go for other departments. I only went for obstetrics and gynecology because I had some few objectives, personal objectives that I wanted to achieve during my rotations, and that is why I went to do nights. For me, this was a very new experience, and it was pretty much challenging in the beginning, but it's something, alhamdulillah, that I got used to and something that I ended up liking at the end of the day. Not in liking, like enjoying the brutal working hours. I got to work, like I would say, like a personalized experience in medicine, because during the day there's so many of us interns. Sometimes if you're in a very busy hospital and if you're like many interns, like for instance the hospital I went to, we were like 50 plus clinical officers, and you would find that is BSc and diploma included, and you'd find that in each rotation we would be like 10, minimally 10 of us in each rotation. So you'd find like there's a lot of things that can slip you during the day, because you're in different wards, you're in different departments within the same rotation, and during the night you're pretty much the person on guard on all these departments. Like for instance, if you are the surgical intern on call, you'll be covering A&E surgery, you'll be covering the general surgery ward, you'll be covering the orthopedic surgery ward, and then you'll also be covering like special cases like ENT, ophthalmology. You wouldn't necessarily do a lot of the things that are kind of specialized, or like the surgeries, of course, and whatnot. You have to have the second on call with you, but then it's a very good learning experience, because you get to first-hand encounter the patient during this particular moment, and then you learn how to deal with that particular thing at that particular point, and then seek consult. Interns were not doing the calls, and for them the work schedule, or like work times, were from 8 a.m. to 5 p.m. The other difference that we kind of had is our logbook objectives and our scope of practice. Now this again, I happened to notice this when I was with my friends, and like we are looking at our logbooks, especially in the beginning of the rotation. We are like, oh, okay, let's go through our objectives and what we need to do and what we need to achieve and what we need to make sure we've done and completed by the end of the rotation. I would find that there are things that would be missing from the diploma logbook and would be present in mine, and that primarily was in procedures. A lot of procedures that were present and I was required to do, you would find that they were either number one, missing from the diploma clinical medicine logbook, or number two, for them it was just the objective was to just observe and maybe assist. And how the logbooks are kind of structured is that for procedures, most of them you end up observing. Okay, not the very common procedures like inserting a line or kind of thing. It's the procedures like doing a cesarean section, doing, for example, incisions and drainages, suturing patients. Okay, those INDs and suturing patients, those were pretty much like overlapping between interns. But then things like cesarean sections, and then things like scrubbing into surgeries, for instance, like XLAPs for ruptured ectopic pregnancies. For the diploma guys, it used to be observe and assist. And then for us, for some procedures, you'd find that the logbook extends and goes and says, do 5, or like do 3, or do 2, you know? So observe, assist, and then do. Observe, assist, and then do. For the diploma guys, like I said, most of the procedures would end at assist, and for us it would be more of like observe, assist, and then do. And again, depending on the institution that you go to, depending on the cultures that are there, depending on the agreements between the clinical officers council and your institution, you'll find that the scope at which you're able to do these things is kind of shaky and dependent on the institution or like the hospital you go to. As an intern, even if your logbook says you just need to observe, nobody has drawn the line for you to assist in that procedure, because your proactiveness is what is going to lead you to that particular point, and nobody will shun you down for the most part if you want to participate in these procedures. And then expectations from your supervisors. While again, most of the things that we kind of did were similar, what was expected from us as BSc interns was a lot more, because automatically we will take up leadership roles in the rotations and take up duties like making the rota, reporting attending meetings on behalf of everyone on the department, doing activities. And for example, if someone was needed to volunteer for something and nobody was willing to do it, we would automatically be the choice to be picked. And another expectations that I would say were kind of low-key, and alhamdulillah our supervisors were trying to not really point them out, but like you would observe, if you've watched the previous video on the channel, you probably know about this, but it's something that our supervisors really made clear, that the kind of questions or like what they expected us to do and know was a little bit more, and compared to what the expectation was on the diploma guys. Now I'm not trying to say that diploma guys are less educated, but by virtue of us spending more time in school and having a fourth, and for some others having gone up to fifth year, you are expected to know more, and by virtue of your degree you are expected to know things in much deeper depth and a much greater understanding. So the questions that we received, the kind of percussions that we had in the ward, were pretty much harder to some extent compared to our diploma counterparts. Now, the other difference, or like the other elephant in the room, of course, is the pay. Now, by virtue of you having a degree, by virtue of you having a diploma, of course, there are differences, and you would find that a BSc intern is paid differently from a diploma intern. Of course, by virtue of the degree, by virtue of the diploma, the degree gets a little bit higher pay, and the diploma guys get a slightly lower pay. But then this again translates into the clinical duties and what each group is expected to do and not do. And if you look at it again, some of the things that were contributing towards making the BSc intern salary a little bit more than the diploma was because of allowances, things like call allowances, and this pretty much translates into what we've already discussed about. Now, my opinion on these differences, while there are a few things that we really don't have control over, and they're coming from the Ministry of Health and the Clinical Officers Council, that we don't really have directives and we don't have control over, because it's the curriculum and it's things that these guys have really sat about and thought about it, and they've created manuals, they've created protocols, they've created objectives and logbooks that needs to be followed by everybody who is descending and governed by these bodies. While that's pretty much standard, we're not going to be talking about that. What I want to say is, from my side and from what I experienced during internship, you are your own limit. I would say this because I used to see diploma interns working very much hardly, more than medical officer interns, more than BSc clinical officer interns. And I used to see, and I know of diploma interns who are their willingness to learn and work during internship was way above here, guys. Because I remember, like, I would be on call and then maybe strolling in the wards or like doing something, and then I come across someone, I'm like, aren't you supposed to be at home? Like, aren't you supposed to be at home at this hour? And someone is like, oh no, I just following up on a few things, finishing up on a few things. And I'm like, okay, that's pretty much impressive. And what I noticed again from the other end of the interns, there are like some people who are like, me, I really don't want to do obstetrics, I really don't want to do these other specialties. I've pretty much made up my mind, I want to do specialty X, and that is all I'm caring for. And what these people will do is that they would, I would say, sometimes ignore some of the things in the departments, and they'll be like, I really don't want to do this, I really don't want to be here, so that they would just put in the bare minimum. And that's pretty much okay, but for me that really beats the goal of internship, of the whole internship experience. Because even as someone in specialty X, you are still going to encounter people with different conditions, and even by virtue of other specialties. For instance, like, even though you're going to be dealing, for instance, with just one part of the body, or like just one particular system, it doesn't necessarily mean that you are not in a position to learn about the other systems. And again, the practice of medicine is not like sometimes you just get this systematic presentations. It's like you're dealing with a person at a whole glance, and you're not just dealing with a particular system. You need to put other factors into consideration. Let's put and paint a picture. For example, if you're aiming to become a dermatologist, you pretty much don't want to do obstetrics, you don't want to do pediatrics, you don't want to do surgery. But then as a dermatologist, there are a few things that are important for you to know. For example, if you have a pregnant patient, of course, you need to know what drugs, interactions, what drugs are teratogenic, what drugs can you prescribe or not prescribe, what other factors in pregnancy are you going to put into consideration, the physiological changes in pregnancy, for example. How do they affect dermatology as a specialty? There is that aspect, of course. If you're saying, oh, I want to become a dermatologist, but I don't want to be touching wounds and everything and patients, really? Because again, dermatology, you are going to be involved in skin lesions, wound healing, and you're going to be involved in other procedural things that involve the skin. And sometimes we've seen it in the hospital that you find a patient who is being managed by a physician, by a surgeon, and dermatologist, and you're like, okay, so this is quite interesting, because they need the dermatologist's input, and for their input to even be valid, they need to have some background knowledge of whatever is that condition and how to deal with it, at least from a dermatological kind of view. So again, coming back to the reason why I'm raising my opinion is that despite all these limitations and like limits that we are given from, I would say, an internship standpoint, it doesn't necessarily mean that you draw a line and tell yourself that this is what I'm supposed to do, this bas khalas, yani I'm supposed to do 5 of these, I'm doing 5 of these. In my training, I remember one particular thing that was pretty much clear. I was told by one of the consultants, one of my mentors back in school, and they told me that nobody has put a limit into the amount of knowledge you can have. You can be a clinical officer, you can be a diploma, you can be a BSc clinical officer, but who has held the limit for you in this tropical medicine textbook and handbook, and told you that as a CEO, or like as a BSc, you're only supposed to read certain topics, as a diploma, you're only supposed to read certain topics, and that is pretty much it. Unless you have that mindset and you tell yourself that, oh, this is what I'm supposed to do and this is what I am required to know, and that's all. Because a lot of that mentality, I think, would come from the way we handle exams and everything, that you still, even after school, you end up still moving with the exam kind of mindset, and I think that is pretty much dangerous in its own self, because again, you are no longer reading for an exam, you're reading for your patients. And I think even for the students who are watching this video at this particular point, in your studies, in as much as you are studying for the exam, always think at the back of your head, you are reading for your patient, and you're reading to understand medicine better, and you're reading to be able to treat your patient better. Because if you have that particular mindset, then you know there's no limitation into what you can read, into what you can know as a medical practitioner. And that's pretty much my 2 cents on what I want to say on this particular topic and matter. While, again, a final disclaimer before we close up the video, these are my opinions, and this is particularly projected from my internship experiences. Of course, like I said, from institution to institution, things could be different. And let me know, guys, in the comment section down below, if you have done internship, what are some of the things that stood out in terms of what we've talked about from your internship center and from your experience as well. Now, the other interesting thing is how different the COs, clinical officer interns, are different from medical officer interns. If that is a topic you want me to talk about, let me know in the comment section down below. If you're interested in this kind of topics where I talk about the clinical medicine kind of career and like course in itself, check out the videos I'll have pinned in the comment section down below. Thank you guys so much for watching. I really appreciate every single one of you. If you haven't subscribed, kindly do so, and I will see you guys inshallah in the next video. Assalamu alaikum.